Good evening and welcome to The Square. Tonight's discussion is going to focus on private healthcare in Rwanda. We're going to discuss how we can drive up medical tourism in the country, as well as look at how health facilities are regulated and accredited in the country. Joining this conversation with us is Dr. Zuberi Muvunyi, Director General of Clinical and Public Health Services at Ministry of Health. Thank you very much for joining the show.
Thank you, Dana.
My name is Dana Mpisi. I'm the host of The Square, and as always, I'm joined by the resident panelists on The Square. I'll start with Charles on my right. Welcome to the show.
Thank you, Dana, and happy Labour's Day to you.
Happy Labour's Day. As well as Ephraim and Berna, resident panelists on The Square. Welcome to the show.
Thank you for having us.
Thank you, Dana.
Great. And happy Labour Day to everyone watching. Before we kick off, as we always do, we're going to have a midweek recap of highlights of the week, and I'm going to start with you, Ephraim, if there's something you'd like to share.
I think this one is a bit semi-scandalous. I'll keep it short. There was a video that went around on social media of a journalist interviewing...
Not a journalist.
You see, so now the journalists are like, no, he's not a journalist. But anyway, a gentleman interviewing a lady and almost sexually... Actually, he was sexually harassing her on this during this interview. Mm-hmm. And it obviously brought a lot of uproar on social media. It was interesting to see. Again, there was a debate. Though people were like, "That's not a journalist." Others were like, "Whether he's a journalist or not, that's not the issue. The fact of the matter is, this gentleman was harassing the lady."
It's terrible. Berna?
Two things. One, I'm following the fight between China and Europe over the 5G network, and I think. We have to pay attention in the developing world to what's unfolding, because we are probably the only neutral party in this. There's a lot of information and misinformation going around. There are security concerns. Whether they are genuine or not, we don't know. But of course, at some point, we'll be migrating to 5G. So I think we need to get interested
in the near future. I don't know I have the sentiment that we're only going to be concerned around 5G in 2022. At least us in the region. I say this on the basis of how we rolled out 4G. The 4G even up to now still. 4G is very expensive.
But like Berna says, it's something to keep a lookout for.
Yeah, I think it's an interesting development, and people in policy, ICT policy, I think need to pay attention to the Ebola crisis. We are seeing that insecurity is a big problem. It's increasingly becoming difficult to contain it because of insecurity. And of course, those are things we take for granted when you have security. And of course, the risks now are heightened, and I think we need to be more vigilant.
Charles, midweek recap?
Two things. One, of course, the noisemaker Sankara, who has been brought to I think where he belongs, and but the second one is something that's continuing to bother me. I don't understand why we continue digging up our city. You know, we lay trenches and channels where all services are supposed to pass, and services being water, underground cables, if any, for fiber optic and all the others. But we just keep digging up the city, and
it's 4G and 5G.
Yeah.
What's
my issue there is really around wastage of resources. It's wastage of resources. I believe there must be a way, and to the best of my knowledge, once on one of the meetings when we hosted somebody from the mayor's city of Kigali, they did mention that there is a channel through which all these services are supposed to pass. But I still ask myself, why do we keep digging up the city? We lay expensive cables. We do very, very expensive sidewalks, bicycle lanes that we never use, but we still keep digging up all the stuff. So I'm worried. There's a bit of wasteful expenditure.
You're not going to comment on the city of Kigali reforms, or at least what had
I
happened.
think that's a show.
A topic for another time. So, Dr. Zuberi, thank you for joining the show. We're here to discuss private healthcare, and in your capacity as a Director General, Clinical and Public Health Services at the Ministry of Health, we thought it would be great to also hear from you. The first question is to you and to my fellow resident panelists is to do with regulation of private health facilities in Rwanda. In April, just last month, media outlets reported the closure of several health facilities due to failure to meet health standards. So first of all, the question to you is why were they closed down? And if you can also shed light on the accreditation and regulation process of private healthcare in the country.
Thank you. But before I answer to that, I want to also to comment on the two highlights.
Oh, okay, interesting.
Not the Sankara RS1, but we are also, as the health sector, we are very interested by the development of, e-health. And for that, we badly need connectivity. So I mean, we need 4G. I don't know if it is expensive or not, but, well, we can always negotiate. The fact is, we really need to connect everybody, and I am happy that more than 90% of the country is covered by 4G. The other thing, we would like to equip our community health workers with connectivity to internet in order for them to report back through the channel, to give alerts, to report on medication stock out, for example.
And then that
So
infrastructure
that is very interesting, and I can tell you that we are seriously discussing with the service provider for 4G to
help with that.
to roll out this technology among our community health workers. So that is very important to us, just because community health workers are so critical in our structure, healthcare structure. The other thing
I
is...
think before Dr. proceeds, if I want to retract something. If all the digging up that is being done is for purposes of the medical sector.
Second is Ebola, of course. Everybody is concerned by really the magnitude of the problem in our neighboring country, DRC. The good thing is Rwanda is seriously getting prepared for that. We have all our point of entry are monitored. Everybody is being screened. We have Ebola treatment centers. We have got equipment, and we have trained so many people, what we call rapid response teams. So this include volunteers of Red Cross at community level. We have community health workers, etc. So the other thing is, right now we are conducting immunization of the first liners, and the vaccine has proven to be efficient, at least to stop or not to stop, but at least slow down the transmission, the spread of the disease. So, but we have to be careful. And again, one of the efficient measures is hygiene and sanitation. So, now back to your question.
Yes. And thank you for your highlight of the week.
What was the question again?
The
Refresh my mind. Yes.
The question was the closure of several private healthcare facilities that took place last month. And also, if you could just highlight for us what were the key reasons for this, and delve into the level of regulation of private healthcare.
And accreditation.
And accreditation.
And accreditation. So,
yes.
Let me start by saying that Rwandans or people living in Rwanda, they deserve, or one of their priority in their lives is health. Probably second will be education, and so on. So, and in urban areas, so we are told that 80% of the population goes to private health facilities. So we have to pay attention. Whether people are getting the right quality with services, health services, and again with quality they deserve. So that is the one thing. So we had to really to inspect and make sure that the quality we want in public health facilities is the same quality we have in the private. So now the question is about regulation, right? Well, we have tools. I mean, regulation tools. We have ministerial instructions. We have, of course, a law related to art of healing. It is not only for public, it is for both public and private. So what we want is to align the services received, whatever the health facility. So for the public health facilities, we have, since 2012, we are health facilities are under accreditation process. I can give you an example. Some big hospitals like King Faisal Hospital, Sashuka, they are being assessed by an international body called SASA from South Africa. But for other facilities, hospitals and health facilities, public health facilities, we have our own standards, and they are being also assessed, evaluated. So we would like to see, I mean, the aim or the objective is to see also the health facilities, private health facilities also being accredited. So following the standard and the regulations. That is why we went to inspect. That is one of the reasons we went to inspect and cross-check if they are following the standards in terms of administration, management, leadership, safety of patients, safety of staff, clinical services, quality improvement in general. So, and they have received already the standard, so they are supposed also to be updated on those standards. But the other thing is, normally before you receive the license to practice, there is a set of requirements, administrative documents you should provide. So do you have, for example, your staff is supposed to have license to practice, being the doctors, medical doctors, the nurses, allied, what we call allied, physiotherapists, ophthalmologists, technicians, dental therapists, etc., etc. So, and we have different categories of private health facilities. So maybe we can explain longer, but that is the general, that is the overview. We have regulation, we have ministerial instruction regulating the operation of a private health facility, being a dispensary, being a clinic, being a polyclinic, being a specialized clinic, being a hospital.
I think for me, I have two, I don't want to call them issues, but I have two pain points. Okay, so the first one I'll talk of more around the capacity. You know, we look at some of these institutions.
The capacity of the regulatory bodies?
No.
The
clinics themselves and the hospitals. You know, we have this belief that people are not compliant because they have made a decision to not be compliant. But the question then comes in is, what has been done to ensure that the expectations of standards meet the capacity to actually meet those standards? There's a joint between the two. But I'll link that now to another point. We had an issue, remember, around the church closures. And I think even the same thing with the restaurant closures. The issue is always, where was the regulator from the beginning? And isn't there a process of continuous assessment? Because, and this is, at least around the churches, there were many churches that were closed, so it caused alarm. With these clinics, I think there were 90 90 of them, if I'm not wrong. I don't remember the exact statistic. But the question always comes in is, how do you get to the point? We saw some of the pictures. How does it get, you look at some of that rubbish, you look at some of the tools, these things don't look like they are 1 month old or 2 months old. These things look like they are years old. So then the question is, in all those years, where was the regulator? Isn't this more a cure rather than a prevention? And is this the style of approach that we should be taking in relation to healthcare, where we say we are going to fix problems versus we're going to prevent these problems? And I think for me, those are the two things. When you try to touch them, when you look at them separately and bring them together, you realize that, one, even around the capacity, or at least capacity building, if it's done from the beginning before somebody's issued a license, wouldn't that prevent some of the issues we see around standards?
Yeah, of course, it is done from the beginning, and there are 2 steps before even you receive a license to operate a clinic or a private health facility. So, first, a team from the district will come and inspect and assess if you are ready to start, or you are good with the standards, with the requirements. That is one. Second, a team from the Ministry of Health, which is the regulator, will confirm whether they are comfortable with the report from the district or not. So after the 2 steps, if you satisfy the 2 inspections, then you receive a license.
What happened in the case of the 90 clinics?
So let me. I'm getting there. So. Now, the thing is, your question is very interesting. Actually, the dynamics are changing somehow. Health care or health services is becoming also another business. And, the policy is to encourage the private sector to invest in the health services, right? So, as a result, we have more and more new health facilities. So, and staff at district level, for sure at ministry level, is not following. You understand what I mean? So that is why we are also looking at another how to involve the private also to be part of the inspection team. That is why we have more health facilities, private, and the staff to conduct the inspection is still the same. That is why one of the solution is to invite and involve the private. Actually, they do have now their own association for private health facilities. So,
but isn't that a contradiction? In the sense that the private clinics themselves are the ones that are regulating themselves.
No, not regulating, yes. At least help to inspect. Okay. You understand? It is like a shared responsibility, and it is not only for the health sector. That is how we operate in Rwanda in many sectors. So think about Umuganda, for example. So it is not only Minalok. It is everybody. It is a collective responsibility. We all want quality and the safety and the best services we can get.
I can almost relate with what the doctor is saying, is going towards auto-regulation. If you look at the chaos we had amongst the motors, police could do just as much. The security organs could do just as much. But when the association of motors came and understood that we actually have a problem as a nation, then the way they ride and safety and security, it was addressed. And let's also appreciate that there would be serious capacity issues. That's where Dr. is coming from, saying I have just as many health inspectors. The district would have just as many health inspectors, but at the same time, RDB and the government of Rwanda and everything are saying go out there and open as many health facilities as you can, because we need you to to pay taxes and open money. I mean, and make money. Daktari and his family are my people, so I might sound like I'm speaking to him, for him. But he mentioned something that has come to my surprise. He mentioned that 80% of Rwandans access private medical facilities. And private medical facilities, yes. But you said about 80% of Rwandans access urban-based, yes.
Because the majority of Rwandans have access to public healthcare.
Yes, but you said 80%, yes. And this is a bit of a shocking fact because I want to link it to Mutuelle de Santé. About 85% of Rwandans use Mutuelle de Santé. Whereas Mutuelle de Santé is not accepted in private medical facilities. So I find that a huge dilemma that the majority of Rwandans have access to a medical insurance that they cannot use in their preferred medical facilities, clinic, dispensaries, and so on. And that's really shocking, Daktari.
It's not shocking, but there is an explanation.
Yes.
I have to repeat that this is in urban area. That is one thing.
You know the definition of urban, even if we are to look at Kigali alone.
Yes.
You will go to, there are parts of Gikomero that...
But urban is, let's say, Gasabo, Chichichiro, and Nyarugenge. First of all, remember that we have like 3 district hospitals in Kigali, city of Kigali. We have Kibagabaga, we have Masaka Hospital, we do have 2 hospitals, actually we have 4. We have Kachiru and Muhima. But Muhima and Kachiru are for mothers and mothers and children under 5. So you understand that they cannot, in any case, handle the population of Kigali, city of Kigali, which is the last figures, I think, more than 1 million. It's 1 million. Yeah. That is one thing. And we do have few health centers. Health centers where they can go and use their Mutuelle de Santé. But still, I said they go to private health facilities. Most of the time it is out of pocket, what is not a good thing. That is why we are encouraging people, again, the private sector, to start operating what we call health posts. Health posts is, let's say, a light health center. But that one has contracts countrywide with RSSB. So that is why we are trying to bridge the gap by encouraging people, even dispensaries, we are encouraging them to opt for the health post approach. Because to respond to your question, we know that many people will go to private health facility. In private health facilities, they don't have contract with RSSB, with Mutuelle de Santé. That is why we are encouraging people to give up with this private dispensaries and start operating health posts. We are in the middle of the road. We are in the middle of the process, but we are progressing very well. Another example of how fast we are progressing with health posts. Last year alone, we had like countrywide 400, about 400. Today, we have doubled that figure countrywide. So, and we hope in 1 or 2 years we'll cover the whole country. The objective is to have a health post at cell level. But again, if the private is also following the standard, why not? Maybe they can They can discuss with the Mutuelle de Santé, and the people can choose where to go. We have two business models, let's say two business models. We have what we call private partnership, private-public partnership. But for health posts, we have what we call private-public community partnership. So, which model? For now, today, RSSB is only accepting PPCP. But who knows? Tomorrow, maybe they'll
Things may change.
As long as they accept to follow the rules, to follow the standard, and to be okay with the regulations.
But it's refreshing to see that there's actually efforts to bridge the gap between people accessing private healthcare, even though they're on a Mutuelle de Santé. Raina, you have something you want to add?
Yes, I just wanted to follow up on the out-of-pocket expenditure and link it to the indicators that you may have in terms of assessing quality, the quality of healthcare given specifically by private providers. It seems like these, if there are any, the indicators that you use when you're licensing them are known to you as the authorities. Yet, the people who have to interface with the healthcare facility are not actually aware of what is standard, what is expected of them, or what their rates are. And why I'm mentioning this is because if we go back, for instance, to the issue of out-of-pocket expenditure, you'll find that most of the time it is because, one, the facility is unprofessional. Why? And how do you see that? You either have unnecessary tests being done, or you have unnecessary medication being, being prescribed, and the patient doesn't have a say in all this. So what I would like you to explain to us is, one, in this whole process of promoting private healthcare, how do you ensure that the quality is maintained, but at the same time, the vision to have a patient-centered healthcare is not lost, because it's easier with the public sector, because you can enforce. How do you,
Well, so if we were discussing about public, I'll actually be more comfortable because yes. We have so many mechanisms. For example, we have what we call, I will say it in Rwanda, ijwi ry'umurwayi. So countrywide, all facilities, they are following up, and they have the right. So that is why actually we are having this discussion here, and that is what we would like to do with the private health facilities. So we want them to give a voice to the patients. Actually, we want them also to undertake accreditation process. And with that, there is one risk area, one set of indicators where we assess, for example, the suggestion box, how they communicate with patient, and how they communicate. I mean, patient satisfaction and the staff satisfaction. So that is why we are doing our best to get them on board and start this accreditation process. But you are very right. And there is a lot of to do in terms of education. We need to educate our people. And thank you for this opportunity. Actually, I hope we will pass the message to everybody. So it is a right. It is a right to have the right medication, the right conversation with your doctor, the right, information from your doctor, and the right, etc. So we need. It is a continuous situation. Even in other countries, even in Europe, sometimes you go to the doctor and you just go in the theater, you don't even know why. So we need to educate people. We need to communicate through different media like this one.
Yeah.
But is there a way that you can have these facilities at least pin, the indicators? Because one element, for instance, if we consider timeliness as an indicator, we spend a lot of time in waiting rooms. So I'm just imagining if at least within that space, the waiting room, there's information about your right.
It seems you have access to what we call HMIS. HMIS is the Health Management Information System. So all these indicators are monitored. And I want to inform you that even private health facilities are reporting in the HMI system. So they are being monitored as well. So last time we conducted a study, not a study, but a survey, like a survey, to compare the waiting time in the private and in public, so that they have they are in advance to the public. It is like 10 times less than the public. So when you go to private, so you are sure you will be received. Sometime the customer care is there, and you are received in a very short time, and you get the service in a very short time. So
Dr. has just said something very interesting. He said sometimes. Sometimes you are received. There are two things about that. First of all, if we are going to talk about medical tourism, we have to stop beating about the bush and get rid of such statements like sometimes you get customer care. Because the hospitals I frequent when either myself or my children have to get medical care include King Faisal and sometimes Legacy. Just to give an example of those two, well, I have visited people at Kachiru, I've visited people at Chiwagabaga, and I will not talk, for example, of one situation where, one medical facility where all the time the customer care is almost acceptable. I need to give King Faisal some credit. The entrance and the search and that process before you get to your first medical practitioner has improved quite significantly. You go to Wiwo, it's a very Wiwo hospital it's what's the word the doctor used about the experience, the patient experience, I think. It's really miles in improvement. However, he said something that does not exist at all in any hospital that I know. Getting an appointment and you see the doctor at the time you have been told you will see that particular doctor. And I asked myself, what is the purpose of seeking an appointment? The health management information system that the good doctor was referring to, of what use is it, yet it is not being implemented? Yeah, so and these hospitals are very good. They have put in place all these mechanisms. You can SMS, you can call, you can send an email, and you will get a response, and you'll get your appointment. But of what use is it when it's just for purposes of ticking his boxes? Because in clinical services at the Ministry of Health, they require you to have a health management information system. Do you have it? Correct.
But in actuality,
the practice, there is nothing.
Yes.
I think that's the point.
I think Charles has a point. But remember, you have two types of waiting time. The first one is when you are sick and you walk in.
Yes.
So that's the first one I was referring to. So in public health facilities, you can wait longer than in a private health facility. But for appointment, waiting time for appointment, so we still have a long way to go. So, but we have some strategies. One of the strategies to strengthen the use of electronic medical record. And for your information, private, they are good. They have EMR systems. But in the public also, we are implementing. All hospitals now are using electronic medical records.
So we're going to get rid of
and
the
one
fish.
of the module is the management of appointments. So, of course, we are at a very early beginning. Let's say we have been implementing this since January. I mean, full implementation. Even at the health center level, we are implementing as well. So it is very, very recent, and we hope with that strategy, with working with even those the service provider for 4G and everything, and the fiber. So we hope to really to improve and to respond to the people demand and the need.
I actually think there's an opportunity. I think there's an opportunity to leapfrog in this whole, especially with appointment booking. Technology has made it so easy. You know, it is possible.
So you agree with me?
Yes, I agree with you. You know, the problem I have is how long it takes to implement, you know, to make use of technology. Already, there are places where you can go and the doctor can give waiting time. So if your appointment, for instance, has delayed, you can get a text and say, your appointment has been delayed probably by 20 minutes or 30 minutes, you know, so that you plan your schedule. But what happens? Well, the current situation is such that people literally need a day off to be at the hospital. And I think that's unacceptable.
Unacceptable.
Because you can understand that
21st
yes. So there has to be a way.
Particularly in Rwanda, where technology and the tools are available and
and where you have government institutions that are actually
but it is like when you are at your university, I don't know where you went for your studies, but you always have A student, C student. So some are doing very, very well. I can give you many examples, but others we really have
lagging
to push.
behind.
They're lagging behind. But we have the hope that sometime very soon they will be part of
Dana, if I may, there's something Doctor said earlier on that I think we need to get a bit of more clarification on, and that's around, he mentioned that they are encouraging the private sector to go into investing in health posts, and the point I got there was that generally speaking the government wants people to invest more and more into health. And I feel that is just a bit of lip service, because what incentives are there to invest in the health sector when it's not like education, where you have duty exempt on certain materials, where it's not like the hospitality sector, where if you're building a hotel and you bring in towels and cups and plates, they will not pay import duty. So the incentives to invest in the health sector, we really don't feel them. And in addition to the fact that even when the guys invest into the health sector and you have all these very prolonged delays in medical insurance companies paying your bills, I mean paying you for whatever services you delivered.
So let me stop you because
I want to stop him too.
But I would like to
just
also
because
I want to stop him
incentives to the private sector.
the incentive.
I want to know the incentives.
There is money to make. That is the first incentive.
Yes.
Why? Can I even ask you how many times a month you seek for medical services, even for checkup? Not only you, your family, people in your household.
No,
that is one
doctor.
thing. That is one thing. And again, I will repeat that the priority now, the two priorities for Rwandan people, it is either health or education. So, the 12 million people in this country, at one certain point, they will seek for health care. So, the question is, they want to receive the best services they deserve. So that is why we are encouraging, not us as health sector, but even I think
But
the country.
can you give us an example of tangible incentives that are actually encouraged, that are given to the private
Then
sector?
I would like to speak
But
to
just very
that.
quickly, please.
I don't think they deserve. I don't think they
But
deserve.
Bernard, please let him answer the question. Are there any incentives that are given?
An example.
Yes, just literally a tangible
Also want to hear what Bernard says.
So in terms of cash.
It could be monetary, it could be fiscal, it could be...
Let me have the private sector.
So, yeah, well, I don't know. I am not in private sector myself, but what I know, we have some data and some data from medical insurance. So the reimbursement to health facilities being the bill to health facilities, being public or private, is constantly increasing. And again, health professionals, so they're happy with what they get, they have.
I strongly disagree on
That is good we disagree sometime. We don't have to agree on
I'd like to
everything.
clarify one thing.
But I'd like to just drive this conversation. We spent an awful lot of time on regulation and so forth and so on.
But now we're moving
panelists,
to...
if you can allow us to also move on to the
Yes.
next part of the conversation, as we're running out of time, it's to do with medical tourism.
Yes.
So I want, if you could share with us, what is the trajectory of medical tourism in this country? We've seen some facilities over the years that have opened up in Rwanda, and some examples are, we all know Dr. Agawal's eye hospital, there are diagnostic and fertility clinics, there are other private clinics that have come up, Baho Hospital, Legacy, Deva, so forth and so have you. If you can give us a sense in terms of medical tourism that we've talked about, what is it like in Rwanda? What is the feel of medical tourism in this country, and what do we need to do to drive it forward?
So, let me share with you my experience in where I'm sitting at the Ministry of Health. Every single day, or at least every week, I receive people from abroad who come to look for information how they can invest in health sector in Rwanda and bring services we don't have here. They are not necessarily targeting Rwanda as such. They may target other
Regions.
The region,
Yes, the region.
DRC, Uganda, neighboring countries, but also other countries like far from Rwanda, in the African continent. Why? You know, travel to Rwanda is becoming easier with the Rwanda Air. And thanks to Rwanda Air for that. And technology is there. And doing business, I think we are doing well. No, we are doing well. So, and you mentioned a few examples, but you forgot one thing. In Rubavu Hospital and in Gihundu, that is in Rusizi district, so the dialysis services are being provided there, and they have recorded. I have the numbers of foreigners or non-resident people coming to seek, and that is private. That is actually private, yes. And I can tell you for one procedure of dialysis, it is $100 US. So. You can understand. So we are somewhere, and you mentioned also Agawar Eye Clinic, Wiwo, and so many others. But we have new project in pipeline, and for example, cardiac center of excellence, probably in Kanombe, in the area of Kanombe, for open heart surgery, for example. We have a comprehensive center treatment, cancer treatment center in Kanombe as well. We have equipment in Kanombe for the radiotherapy, which is not available in the region. So a very advanced equipment. So, so with that, we are expecting to attract people, and it was 2 years ago, it was like a dream now, but it's becoming somehow a reality. It is becoming a reality, not only because the example you mentioned, but we have those very tangible and the practical projects in pipeline. I forgot to mention IRCAD project. It is like a several million US dollar budget. That is a center of excellence not only for minimal invasive surgeries, but also to train surgeons coming from across the world, and that they will be paying also. It is not only it is medical tourism, but it is also, let's say, also education tourism, medical education tourism. Yes,
that's interesting. Yes, that's
so I think it's good to note that a lot has been done, and there's so many things that we could lay claim to. But I want to take medical tourism in the same light as we take normal tourism. What is our edge? You know, globally, when you look at the global medical tourism sector market, you have 80% of that market being shared with it's Thailand. I think Thailand is the leader, Singapore and India, and they control 80% of the medical tourism market in the world. Globally.
Yes.
Now you ask yourself why. Apparently it's two things, right? It's affordability and quality of service. And you find, even from an accreditation perspective, we talked about this, but we'll talk about local accreditation and maybe regional accreditation. But I know most of these international organizations get accredited by an institution called the Joint Commission International. But what I've seen at least from what I've heard, at least for us to be able to be competitive, to get people to come into our country, choose our country versus maybe the next country or the other countries, not necessarily having the equipment or having the facilities, but also having quality of service and it being affordable for these people to come in. And I think that, for me, is the question then comes in is how far are we with that? How far are we in terms of, and I think this is the question I keep asking. I asked the first time around capacity. Do we have the capacity to really meet the demand we desire to attract? Because I'll give you a simple example. When we talked of the MICE strategy with meetings, conferences and events, we built the facilities and the infrastructure, and we also built the capacity. So a lot of money was spent. I know even MasterCard Foundation now has a program to build capacity within the tourism sector, and they're investing so much money through various other subcontractors to build capacity. They're like, at the end of the day, as much as we want people to come in, do we have the capacity to service that? Hotels were built. And coming back to the private sector, incentives were given. Now
so
the
in
question,
the health industry,
yes. When we look at this, as much as we say we've ticked this box, it's just one piece of many. It's one piece of the puzzle. There are so many other aspects that have to be looked into, and what's being done.
Well, if your question is, do we have the 100% capacity?
Or the infrastructure?
Do we have enough?
For now, yes, we do have enough to start something, and we have already started actually. And I will repeat that these people, the same people you are mentioning from India, from Singapore, and even US, they come here and they ask for opportunities. And sometimes we then share information through emails or something.
So why haven't they started?
The second thing, no, they are starting slowly but surely. The second thing, there is something that we call telemedicine. I mean, in between, before we get full capacity, 100% capacity you are talking about, we have started using telemedicine. That is Legacy is doing actually, I think. So they can get a test from you, send the sample something or the image to India in 5 minutes you have the response, and the doctor can start treating you, because most of the time it is about diagnosis. So it is a process. It is a process. You can't have everything now, but it is a process, and we are somewhere. But of course, we need to be innovative, to think differently, and see why if we have actually all opportunities. Have opportunities here really to become like a center for medical tourism, just because of technology, just because of we have so many things. I don't want to to discuss something I'm not really comfortable with. But I believe we have doctors, and again we can interact with doctors in India. Let me tell you something. We have some private health facilities here, and the hospital in India, they want to come and invest here. And for example, so, and I already mentioned the WIWO, the WIWO hospital, Agarwal hospital. It is an Indian-based hospital. So
I can understand.
Everything is possible. The only thing we need is transparency, good leadership, innovation, be proactive. So it is really possible. And again, so many people are in our neighborhood, I mean the region, they are coming here in Rwanda either to get treatment or even get a transfer to those countries. So, you know, I am very optimistic that we can do something, and we are already doing something.
You know, but now when you have an RDF colonel who is a medical doctor working for the government of Rwanda in the public sector, it is very difficult to corner him.
I don't think there's need.
But I want to say something around. I can understand why the government of Rwanda is getting a lot of requests for people to invest in the health sector. And that's because largely the Rwanda Medical Referral Board spends probably billions, or has spent billions of dollars in referring patients to facilities abroad for different complications. So we've helped other people build hospitals. So probably I wouldn't be shocked that the owners of those hospitals are now coming to Rwanda and saying, no, let us spend our money in building a hospital in your country so that we can make some of it. And I know Baho is building a huge hospital in Nyarutarama, you know, and the legacies and so many other people have invested. But my bigger bone of contention is really around if we can see that opportunity, and let's not, Daktari, blame ourselves so much on wanting to achieve more. The little that we have, and this is really our bone of contention, all of us, the little that we have, let's do it properly. That's really our biggest issue. For instance, in the nursing department, there is no reason whatsoever why we should not have nurses that do a good job in their respective facilities. And I want to go back to this whole issue of Mutuelle de Santé. Because Mutuelle de Santé does not allow you to go to a private facility, so therefore what people do is they will have that Mutuelle de Santé, and I'll go to category 2 and 3. They will have it for purposes of ticking the government box and looking good in terms of your Muganda records. But they will go to the Britam and the UAP and spend hundreds of thousands of francs with this foreign medical insurance provider. Which money, and I think I really would encourage you people in the public sector to look at, if that money was given to our own medical insurance scheme, it would have a bigger impact on our government, because that is money that is remaining in our system, and that allows us to be able then to go to the private medical facilities. Ask me, I pay almost 1.5 million francs at Britam for my family medical insurance. Give me an option to pay the same amount of money to Mutuelle de Santé or less to Mutuelle de Santé, get the same facility in the private medical facilities, and I'll mobilize everyone I have ever heard about to do the same. Yes. So I think there's a bit of a loss of there's a loss in opportunity there. You may nod your neck off, Bana.
Just one second. I'd like to hear from Bernard. Why do you disagree?
I disagree.
I think that's a good idea.
Yes, I disagree at 2 levels. One, going back to the issue of incentives. The health sector is already benefiting from our investment code. There are several incentives. That is one. Two, when you look at research that has been done, investors are not really looking for physical incentives per se. They're looking at the ease of doing business. They're looking at areas that are where there's less corruption, less bureaucracy. That is what drives investment. So for me, I don't think we have issues around incentives as such for the private healthcare. That is one. Number two, we need to think about equity. When we are pushing private healthcare, how do you take care of the vulnerable in our society? Because if you leave it to the private sector, it will be, if I have made my investment of 100 million, then it has to be reflected in the costing of the care that I give. How do you balance that? Now, going back to what you're saying, I think the whole medical insurance is a whole different discussion. But I think we need to spend more time on the policy side, ensuring that we have proper accreditation processes. We have proper indicators that are guidelines for the private health practitioners. And why do I say this? We need to know that if I'm paying money at Legacy, this is what is expected. As we speak, that is lacking. And in what areas? For instance, in terms of effectiveness, if we are talking about the quality of care and we are talking about effectiveness, linking science to care, at the moment, it's a big issue. And why do I say that? You'll have prescriptions that are not necessary. You're not linking science to care. We will have outdated drugs.
We have come to the end of the show. Unfortunately, this is a very interesting topic.
We still have like 5 minutes.
Unfortunately, we have to get ready for the news. But thank you very much. I'd like just very quickly, we really have to wind up. If you can just give closing remarks on this particular topic.
So, closing remarks, first of all, thank you for this very interesting discussion.
Yes.
It was not for you or for me. It is for everybody to understand, in particular people, being our friend from private health facilities. So we have regulations, we have standards, and the accreditation and the standard and the quality are really catered for, available, but of course we need to put more emphasis on the implementation. Yes. And again, equity, the Mutuelle de Santé, yes, community-based health insurance is something critical. Myself, I call it a center for gravity for our health system. So we have to protect it at all costs.
Doctor, thank you very much.
So we have to balance, yes, and can ensure that everything is done to make it to stand. And we are also looking into possible solutions for sustainability.
So, Doctor, thank you very much. We've come to the end of the show. I think we should have part 2 of this.
We
Charles,
definitely
you had a lot to say, but thank you for honoring our invitation.
And I'm ready to come for the next season.
Fantastic.
And discuss other topics, hot topics.
Thank you. Thank you very much. Thank you very much to the panelists. I'd like to also thank our partners, Uzi Collections and Bourbon Coffee. And to our viewers, thank you for watching and see you next week. Have a good evening.